most of y'all have seen me before, and some of y'all know my name if I've gone to clinicals with you, but my name is Larisa Ziegelmann, and I'm a nurse educator student from UMMC, and I'm going to be teaching y'all today about peripheral vascular disease. So before we get started, we're going to do a little pre-test, and then after the lecture, we'll do a post-test, but it's front and back. There's not a grade for y'all, it's just kind of an evaluation purpose for me in case I don't break out. I know I've already had a test today. So I think there's enough. If I give you this packet, you take one and just pass it down. I think there's enough for everyone on your row. But if you run out, let me know. I have some extra. Yes, and actually, instead of putting your name on there, because like I said, it's not for a grade, it's just for my evaluation purposes only. If you will, just put your student number on there, that'll be fine. No, like on your roll, if you want to, that'll be fine.
I might not know.
Oh, the student roll numbers?
And then when we get to the post test, you'll just put the same number that you put. You can just, if you don't know it, just put one.
Or you can put your initials or something, that's fine.
Or your initials, just as long as the front sheet, whatever you put on the front is the same as what you put on the back. Be fine.
Just put your initials, okay?
Did everybody get one? Let's make sure. Yeah, make sure y'all are on the pre-test. It says pre-test and then page 1 at the bottom. I'll give y'all 8 minutes, okay? 3 minutes left. Everybody had time to finish. Cutting you a little short, but I think everybody's finished. Okay, so we'll go ahead. So peripheral vascular disease, when we say peripheral, what are we talking about? Our extremities, whether that's our arms or our legs. And then vascular, what's vascular? Veins or arteries, blood vessels. So that's what we're going to be talking about today. We're going to be talking about diseases or disorders of the veins and arteries of our arms and legs, okay? I'm a very visual learner, so I wanted to review. I made this little diagram. It may not make sense to you, but I'm going to try to explain it. But I just wanted to review normal blood flow through the veins and arteries, and then we'll talk about how peripheral vascular disease, how it is abnormal. So if you can see the little arrows, these are the arteries, and they carry oxygenated blood from the heart to our tissues, okay? So arteries carry blood away from the heart. And then what do veins do? Yes, once the oxygen has gone to the tissues and they've been all used up, the blood returns to the heart through the veins, okay? And most of the pictures and things that we're going to show you are going to be dealing with the feet, but it can happen to the upper extremities as well. So when we have peripheral artery disease or PAD, then there's some type of obstruction in the artery. So you can see that I have this little artery down here is trying to get to the toes, to the ends of the tissues here, but there's something obstructing it, okay? So we can't get oxygen to all of our tissues. There's nothing wrong with the veins in arterial disease, okay? So it's just trouble getting it to the tissue, but the flow back to the heart is perfectly normal, okay? And then with venous disease, we can get blood, oxygenated blood to the tissues, we just can't get it back to the heart, okay? There's some type of obstruction going to the heart. So we have some type of obstruction. Most of the time it's just going to be a narrowing with arterial disease. So there is some blood getting to the tissues. So the blood that does get there, there's nothing wrong with it going back to the heart. And I say that because you'll have some signs and symptoms that'll make sense when you get to that. Okay? So yeah, the blood going, the oxygen and blood going to the tissues is obstructed, but the ones that do get there, they don't have trouble going back to the heart. That's why there's nothing wrong with the venous system. So with that being said, we have some clinical manifestations that are very distinctive and very different if we have arterial disease versus venous disease, okay? So pain for arterial disease, they have a very specific pain called intermittent claudication. So claudication means muscle pain, And it's intermittent because they only have pain usually when they're exercising. And a lot of times that's one of your first symptoms of arterial disease. They say, I've been going out walking every day for the past 3 years, and then the last couple weeks I walk around the block and then my calves start cramping. And it's called intermittent because they sit down and they take a break, and after a while it subsides, okay? But when we're outside walking around and exercising, what does our heart do? It goes up because we need more oxygen, right? So basically that's why they start to have that cramping feeling in their legs, because they're not getting the oxygen that they need to those extremities. And when we rest, our heart rate goes down, okay? So we don't need as much oxygen. So that's why they have the intermittent claudication. And then later on in the disease process, they may have something called rest pain. And this is like when they go to sleep at night, when they're resting. What happens to our feet when we're resting, when we're laying in the bed? When we're laying in the bed, where's the pain? And our feet are at the level of our what? Our heart. And so if we're already having trouble getting oxygenated blood to our feet, and then we elevate them to the level of our heart, what's that going to do? It's going to decrease that blood flow even more. So then if we can't get blood to that extremity, it's going to start cramping in the middle of the night, and they're going to have to get up and then help to get that blood flowing back to that extremity. So that's where they'll see rest pain. If we have a blockage in our artery, what do you think the pulse is going to be like? Weak. Yeah, it's going to be weak. If there's a total blockage, it may be absent. And then sometimes arterial disease only affects one leg or the other, so they may have unequal pulses. So one leg may be normal, and then the other one may not have a pulse at all. So if we have trouble getting blood to our extremity, do you think there's going to be edema? No. Okay? Because you'll see it in the venous disease because it pulls there and it stays there. But if we already can't get blood to the extremity, and then nothing's wrong with our venous system, the blood that goes there is just going to come out. So you won't see any edema, usually with arterial disease. If we can't get blood to our extremity, do you think it's going to be warm or cold? Cold. It'll be cool. And like I said, sometimes it'll only be in the lower extremities that they have this, and not the upper extremities. So you can kind of test, put your hand on the legs and test the temperature, and then test the temperature on the upper extremities, and it should be different. It'll be a lot cooler on the lower extremities. If we can't get blood, oxygenated blood to our extremity, what color is it going to be? Blue. Good. Blue, some of them may have like a grayish tint. And then they have two specific things called elevated pallor, which means we already kind of talked about this. If we elevate the legs, we decrease the blood flow, and so they become really, really pale. That's what the elevated pallor means. And then they have something called dependent rubor, which just means when they dangle their legs, then that kind of increases the blood flow rapidly to the extremity. It may sit there a little while, so they'll have a redness when they have it in a dangling or dependent position. Their wounds, arterial wounds look very different than venous wounds as well. So arterial wounds, they're going to be regular in shape. They almost look like somebody got a hole puncher and just hole punched their leg. They're perfectly round. The edges are very regular, and they tend to be on the heels and the toes. I would say at least below the ankle somewhere. Okay, and they usually occur over pressure points of the feet. So they may be like on the side of the feet. other really interesting changes that happen. They have, and I explain this a little bit better later on when we get to the diagnostic part of it, but their blood pressure in a normal patient, is our blood pressure pretty much the same in our upper extremity as it is in the lower extremity? It should be pretty close. Sometimes you may have a little bit higher pressure in the legs than in the arms, but roughly right around the same. When we have arterial disease, like I said, most of the time it's going to affect the lower extremities. If we have blockage in our lower extremity, what's that going to do with the blood pressure? It's going to decrease it, right? And so that is one of the changes, the significant changes that you'll see in arterial disease, is that their blood pressure is lower in the lower extremity than it is in the upper extremity. And then some other characteristic signs of arterial disease is kind of what the legs look like. And I think you've probably already learned this when you did your history and physical and stuff like that. What are we looking for on the legs? If we don't have good blood flow, we don't get oxygen to an extremity, it starts to kind of die, basically, right? So they have very thin skin, they have very shiny skin, and there's pretty much none or minimal hair growth on that extremity as well. They'll have some dryness of the skin, and then their nails look really, really thick too. Have y'all taken care of anybody in the hospital yet? When you looked at their feet, their toes were just like super thick, and you're like, how does that even happen? Okay, they probably have some type of arterial disease going on. So positioning, basically positioning, we're talking about their feet or their legs. What type of position do you think we're going to have these patients in? Their legs lower than their heart. That's right. Dependent. We don't ever want to elevate it to the level of the heart or even above the level of the heart, because that's going to decrease tissue perfusion even more. Does that kind of make sense? Now that you know the normal blood flow, if there's something obstructing in the artery, those signs and symptoms kind of make sense, don't they? So now we're going to switch over to venous disease. They usually have dull, aching, constant pain, okay? If something is wrong with just our venous system, remember with venous system, there's nothing wrong with our arteries, it's just our veins don't want to get blood back to the heart. There's something obstructing it. Is there going to be anything wrong with their pulse? No. Their pulses will be normal, okay? The only trouble you may have is they're going to have some edema, because the blood's going to get to that extremity, but it's going to stay there, okay? It's going to be pulled there, and it's going to stay. So they're going to have some edema. And so sometimes it's hard to feel a pulse if they have a whole lot of edema, okay? But if you were to get a Doppler and listen, put it over that artery, artery's going to be fine. You're going to feel a pulse, or you're going to tell that there's a pulse there. So the problem is not getting blood to the extremity, it's getting it back to the heart from the extremity. What about their temperature? What's their extremity going to feel like? Yes, it's going to be warm. What about the color? It's going to be a reddish, brownish color. They have something called stasis dermatitis, and it's just like this, like a molting brown looking color over the, like the caps. But it's just because they're getting oxygenated blood to the tissue, it's just staying there. Their wounds look very different as well. They're usually irregular in border. They almost look like jigsaw puzzles, jigsaw puzzle pieces. They're very irregular. They're going to be on the lower leg or around the ankles. They're usually not on the, not on the feet like you would see arterial disease. Okay? They're usually on ankles or above, on the lower legs. Some changes, they'll usually have some thickening of the skin. They may have some possible scarring, and that's kind of the look that you'll see with the stasis dermatitis as well. Looks really thick. Skin looks pitted almost. And I've got some pictures throughout the presentation too that will talk more about what they look like. So with these patients, if we are having trouble getting blood back to the heart, how are we going to position them? Elevate their legs, okay? As much as they will tolerate it, okay? Keep them elevated. What are some handy-dandy devices or things that we can put on their legs to help increase blood flow back to the heart? SCDs, if we're in the hospital, we can put SCDs on them. If they're at home, we can put head hoses on them. So the last thing that I wanted to go over is just some nursing interventions or some assessment things that you would do for patients like this. This is kind of a broad overview of what we'll be discussing through the rest of the presentation. So we're going to assess the 5 Ps. Is there pain? We want to, because that's very different, right? Are they having pain when they're exercising, or is it constant pain all the time? Pallor, what does it look like? What color is it? Is it blue, or is it the reddish brown colored? Pulse, do they have a pulse? Or do they have a pulse? Do they not have a pulse? And then the paresthesia and the paralysis is usually going to be with arterial disease, okay? If they have numbness and tingling, that's because they're not getting the oxygenated blood to the extremity. And so usually it'll start out feeling numb and tingling, and then later on in the disease, it may basically damage the nerves due to the lack of blood flow, and they may not even be able to use the extremity anymore. So the next thing are some safety things. What are some safety things that you can educate your patient about if they have vascular disease? That's right. We're gonna. What are some things that, or activities that would impair blood flow? Tight shoes, constrictive clothing. When you sit down in a chair all the time, what do we always want to do? Cross our legs. Okay, that constricts blood flow. We can avoid extreme temperatures, especially with arterial disease, because they have numbness and tingling. We want to make sure that they're not using heating pads, okay, or getting in hot tubs, because they can't really determine when it's too hot. Okay, so that can cause even more damage. We want to assess the skin, particularly what? Their feet. Okay, we want to assess their feet, especially with arterial disease, because if they can't feel it, there may be some type of injury and they don't even know it's there. We talked about proper shoes. Okay, wear some shoes that are going to protect them. And if they do have a wound, then we need to educate them on some wound care. I know that was a lot for y'all to write down. Did everybody get everything? Okay. We'll go on. So this is a little diagram that I used to help you maybe determine how to position your patient. So if they have venous disease, what are we going to do? Elevate. If they have arterial disease, what are we going to do? Dangle. Okay? So a lot of this will just be text for what we already just talked about. But peripheral arterial disease or artery disease, PAD, is a progressive narrowing of the artery. Okay, and a lot of times, which that's on another slide, PAD is the most common type of vascular disease, and we already said that it occurs mostly in the lower extremities. a progressive chronic disease, but it leads to prolonged ischemia, and then that's why we have the skin issues that we talked about. Their skin doesn't have much hair growth on there because of the lack of oxygen. It becomes really, really thin and brittle, and after a time, it's going to do the same thing to the muscle. So you'll see muscle atrophy as well. And then the leading cause of PAD is atherosclerosis, which is narrowing of the artery due to some type of plaque buildup. So more than likely, this patient's probably going to have high cholesterol as well. Here are your risk factors for somebody that may be at risk for developing PAD. Tobacco use. When somebody smokes, it causes arterial inflammation, and so that can cause buildup in the arteries as well. High cholesterol, we talked about that. Basically what they're eating can cause that high cholesterol. Hypertension puts extra pressure on the arteries. And diabetes, they're usually going to have some like excess sugar in the blood, and so that's a risk factor. Obesity puts extra pressure to somebody that has excessive stress. It's a contributor to PAD. If they have a sedentary lifestyle, so if they're just not very active, that puts them at risk. And obviously, if they've had a family history of PAD, that's going to put them at risk as well. Here's a picture of what it pretty much looks like in the artery. This is plaque buildup, and you can see how it would inhibit blood flow to that extremity. And there's not really a whole lot of room left here, and it will completely obstruct blood flow to that extremity. These are some common sites for PAD to develop, and there's a picture later on that has the different sites. The iliac artery, femoral artery, popliteal, tibial, and the peroneal artery. And here they are. And diabetics tend to have arterial blockage below the knee here, most commonly in the anterior and posterior tibial. And then non-diabetics tend to have it above the knee, usually somewhere in the iliac artery. And depending on where they have the blockage as well, it may determine where they have that intermittent claudication. If somebody has a lower blockage, they're going to tend to have cramping in their calves. But if they have blockage way up here, where do you think they're going to have cramping? The thigh or the gluteals even, okay? So the higher up the blockage, the higher up the muscle that's going to be cramping. Yes, so the higher up the blockage, the higher up the intermittent claudication. So if you have blockage down here, it's going to cause calf muscle cramping. If you have blockage here, it's usually going to cause thigh cramping. If you have it way up here in the iliac artery, it's more than likely going to cause gluteal cramping. So like I said before, that intermittent claudication is probably going to be one of your first symptoms that they're having arterial issues. We said it's that leg muscle pain that's caused with exercise. And usually, like we said, you know, once they're the decreased need for oxygen after they quit exercising, when they stop and take a break, it will usually resolve within 10 minutes or less if it's arterial disease. And like I said, it is a progressive disease. It's a progressive disease, and so it takes a while for you to start seeing symptoms of this disease. Most of the time, they don't start showing symptoms until it's like 60 to 75% blocked, okay? We talked about the paresthesia, which is the numbness or tingling, usually in the toes. Mm-hmm. Yeah. 60 to 70, somewhere right there. They gotta have a good bit blocked before they start having symptoms. So numbness and tingling, usually of the toes and the feet, and this is because they have pretty much the nerves or the neurons in the legs. They're not getting oxygen like they're supposed to, so they start to die basically. So that's where they get the loss of pressure and deep pain sensations. And so since they have this decreased sense of feeling, we need to make sure that they take care of their feet. Make sure that they're inspecting their feet every day. And a lot of times, I don't know if y'all talk much about diabetes, but it's kind of the same symptoms that they have with diabetics. They lose the neurons due to the excessive sugar in the blood. It damages the neurons, so they have the decreased sense of feeling as well. So some people, you know, if you have a rock in your shoe and you're walking around, are you going to feel that? And what are you going to do? Yeah, you're going to take your shoe off, take that rock out. But if you don't feel it and you're walking around all day, think about being a nurse, okay, and you're on your feet every day, and you don't feel that rock. By the end of your 12-hour shift, what's that rock going to do to your foot? You're going to have a hole, some type of ulcer. Okay, and if you don't go home and inspect your feet every day, then that's just going to gradually get worse. You may get an infection in it. So it's important for us to teach them about things like that. Here's some of the other clinical manifestations. We talked a lot about the skin, how it's going to be thin. The skin's going to look really shiny. They're not going to have much hair, pretty much no hair growth on that extremity. We talked about the pulses. Most of the time the pulses are going to be weak or not even present. What's that going to do to the capillary refill? If you check capillary refill, it's going to be slow. It's going to be delayed, okay? They'll have that pallor or the paleness of the foot when we elevate the extremity. And then the dependent redness or dependent ruber. And we talked about the temperature changes too. They have peripheral arterial disease in the lower extremities. They're going to be really, really cool versus the upper extremities that may be warmer. And then the rest pain or the pain at rest. Remember we talked about this usually occurs at night because the feet become elevated to the level of the heart. And it's just from a decrease, an even more decreased oxygenated blood to the extremity. They have poor tissue perfusion. And a lot of times the pain becomes so bad that it'll wake them out of the middle of the night, okay? And so in order for them to, you know, to fix the pain, they have to get out of the bed, they have to dangle their feet. They have to get up, walk around, and if you did this every night, multiple times at night, what are you normally going to do? They usually sleep in chairs. Once they're just like, okay, I'm fed up with getting up every night, multiple times at night, I just sleep in the chair. That way their feet don't ever come to the level of the heart. I don't like sleeping in the chair, so that would be awful for me. So some of the complications of PAD, we said that it was a very progressive, a slow progressing disorder, but as it gets worse, they have prolonged ischemia, and it leads to some major complications. When we talked about the skin, it becomes very thin, the muscles even may atrophy. They're going to have delayed wound healing, okay? So even if they have surgery on the leg or something like that, they're going to have delayed wound healing. If they get an ulcer, then it's going to take a much longer time for us to heal that ulcer, even if we can get it to heal. So we talked about teaching them proper wound care, because we definitely don't want them to get an infection in the wounds, because that could lead to tissue necrosis or even getting gangrene in the wound. And they develop into arterial ulcers, and especially if they get gangrene, sometimes patients have so much pain from the ulcers that and we can't get them to heal, so we just kind of have to amputate that extremity, which is not best case scenario. So here's an arterial ulcer, and some of the things that we talked about. What do you see in the picture that's specific to arterial? It's perfectly round. Remember I said it looks like they almost hole punched it out. Yeah, you can see the toenails over here, very thick. What else? Okay, yeah, I see the discoloration of the foot. Do y'all see any hair on that foot? No hair. There's some other specific things that I want to tell you about the wounds, specifically about the wounds. Does it look like it's going to drain much? No, they have very minimal drainage in arterial wounds. And the bed of the wound, there's not really, no really signs of new tissue growth there. And a lot of times you'll see the yellow, slothy looking stuff, and they tend to be a yellow brownish color. And what about the placement of the wound? Where is it? Remember we said they're going to be somewhere usually below the ankle, usually on the toes or the heel, or y'all know that little bony place that you have right below your big toe? That's kind of like what that one is. So over those bony prominences of the feet, you'll see them. So some diagnostic studies. We talked about the Doppler. Has anybody seen a Doppler being used in the clinical area yet? No? You have? It's kind of just like a little handheld machine. It's got like almost looks like an ultrasound probe on there. And you can just find an artery and you can kind of hear it. You've probably heard like a sonogram where you hear that. That's kind of what it sounds like. But we can use Dopplers. That's really just to kind of see if they have a pulse. It's not really like a diagnostic thing that we can do, but it does help. We can do the Doppler ultrasound with the duplex imaging, which is a little bit better in diagnosing. You can actually see the blood flow when you're looking at it on the screen. They have the segmental blood pressure, and I know y'all don't have this picture, but it was really hard for me to kind of explain it, so sometimes it's easier just to show you a picture. But this is the segmental blood pressure, and usually some type of ultrasound technician does this procedure, but basically remember what I told you, the lower extremity, the blood pressure is going to be a lot lower if they have arterial disease than if it was in the arms. So these are just blood pressure cuffs, and the lower extremity has at least 3 different sites that they put the blood pressure cuff on, usually like the thigh, the knee, and then like calf or around the ankle. And they use this little ultrasound Doppler thing, basically like what we would use with the stethoscope. We pump this blood pressure cuff up and then listen for the first sound, the systolic pressure. They're doing the same thing except for they're like visualizing it. So they get a really accurate reading of the systolic blood pressure with this little probe. But that's pretty much what it is. And anyway, they get these results, they send it to the physician, and they read it. So some type of technician is going to use the segmental blood pressure. And then going back, kind of the same concept, but a nurse can do this one. It's called the ankle brachial index. And this is where we are going to compare, basically, the blood pressure in the lower extremity with the blood pressure in the upper extremity. And we're going to be comparing the systolic pressure. We're only going to be using the systolic pressure for this, okay? So basically what they do is they get a reading in the ankle. So say our blood pressure in the ankle was 100/62. And then we get a blood pressure reading up here in the brachial artery, which we say is 115. So we'd say 100 divided by 115, and that gives us our index. And I think there's a page in your book that gives you, is it always ankle divided by brachial? Yes. It's always going to be ankle divided by brachial. And remember, we're only looking at the systolic pressure. So on page 805 in your textbook, table 37.3, kind of tells you more about like what the results, whether it's a mild case or a moderate case or severe case, depending on what value you get, okay? So I want to do a little example here. So your patient has a brachial blood pressure of 133/87, and the blood pressure at the ankle is 107/64. Determine your ABI and round it to the nearest 100. Y'all have a calculator? What do you get? That's right. 0.80. And I think that's a mild case. Because we want this to be as close to 1. That's considered normal. 1 would be normal, okay? But you have your different ranges. But this is just a mild case. But that's how you figure it out anyway. The other ones that we haven't talked about, angiography and the MRI. These are just tests that we can use to visualize. They're more diagnostic than the other ones because they actually go in there and visualize the blockage. Let's see, I think I got a picture of it. Here's the angiogram. And y'all can kind of see, even though this is in the coronary artery or an artery in the heart, it's the same concept. You can kind of see right here, there's decreased blood flow. There's some type of blockage right there, and this is what we want it to look like. But this is, like I said, it's more diagnostic because they can go in there and actually visualize the arteries and see what's blocked or what's not, what is not blocked. So there's basically 3 things that we can do for people that have arterial disease. We can help them do lifestyle changes, we can give them medicine, or they can have surgery. So we're going to talk about each one of those. Lifestyle changes, we said one of the #1 causes of PAD is smoking. So we want them to quit smoking. They can use nicotine patches for arterial disease. Some exercise. One of the most effective treatments for PAD is regular exercise. Even though they have pain when they exercise, the more they exercise, the decreased amount of pain they should have. Even though they may have to stop and take breaks frequently because it is painful, they do have some cramping, encourage them to stop and take breaks, but don't just stop exercising, okay? Because that's going to make it even worse. We want to help them maintain that good body weight because remember obesity puts extra pressure on the arteries. Nutritional therapy as well. A lot of times diabetics have PAD as well, so we want to help them monitor their blood sugar levels, help get their blood pressure down. And remember that atherosclerosis is the most common cause of PAD, so we want to help them get their cholesterol down as well. And there's a page in your textbook right here, 1151, table 4821. That's got some excellent education on proper foot care. So a lot of times they'll try lifestyle modifications first, and sometimes patients are not compliant with the things that they're supposed to be eating or doing. So the next step would be to put them on some type of medication. So the antiplatelets, sometimes they can just take a baby aspirin or 325 aspirin. Sometimes they have to be put on Plavix to help thin the blood. They're most certainly going to be put on some type of statin drug to help lower that cholesterol. And if they have just, if they complain so much about the intermittent claudication, it's kind of their big issue, then there's two drugs that we can use for that, the Platol and the Trintol, and they just help to decrease platelet aggregation and stickiness of the platelets and stuff like that. So if we've tried lifestyle modifications, we've tried some different medications, and that's still not working, then the next step would be to do some type of procedure or surgery. So the first ones we're going to talk about are procedures, and then the next is surgery. So most commonly, they're going to have that percutaneous transluminal angioplasty, or PTA. And this is basically a catheter that they insert through the groin, go up through the artery, wherever they have the blockage, and they use some type of balloon on the tip of that catheter, and it pretty much inflates and opens up that artery. And I've got a picture later on, it may make more sense, okay? And most of the time, once they use that balloon to open up the artery, they're going to put a stent in that place to keep it open. So there will be a metal stent in that artery. And then sometimes, which is not as common, most of the time you're going to just see this, the atherectomy, where they go in with the catheter, and it kind of like, it's got almost like a drill bit looking thing on the end, and it goes in there and breaks up the plaque and then sucks it out. Okay? But most commonly you're going to see these up here. So here's the picture of the balloon. So it just gets inserted into the artery, goes to the area where there's blockage, it inflates. So think about that picture that I showed you earlier about the blockage. Okay, it inflates, pretty much pushes that plaque out of the way, and then they go in there and put a stent in. The stent?
How long is the balloon?
Oh, just long enough to put the stent in there. So it's pretty much on the same procedure. You go in there, put the balloon in there to move it out of the way, and then they put the stent in there to keep it that way. Does that make sense? Some places, it's not very common. Most of the time, if you have to get that balloon to stretch it, they're going to go ahead and put a stent in there because they won't have to do it again. But some places will just try doing the balloon and moving it out of the way. More than likely, it's going to come back. Okay, so that's why they go ahead and put the stent in there at the same time. Okay. The important thing to know about the stent is it is a piece of metal that's going to be in the body. Okay, so that's a foreign object in the body. What's the body going to try to do? Try to get rid of it. It's going to try to clot, and it's going to clot. Okay, so it's important that they take their blood thinner medication when they have stents. We preferably want them to take it at the same time every day. Sometimes that's they're not able to do that, but that's what we like to encourage them to do. Take it at the same time. Make sure that they take it every day. Okay, and so then the next one, the surgical procedures. Most commonly, you'll see the peripheral arterial bypass surgery. And most of the time, you hear it called a fin pop. And it is a femoral popliteal bypass surgery. Femoral popliteal, or a fin pop. So femoral, if we're doing femoral popliteal bypass, what do you think is going to happen? We're going to use a vein, so we're going to get another blood vessel out of the body, and we're going to go from the femoral artery, y'all remember the picture I showed you? Femoral artery to the popliteal artery, which is the knee. So basically, we're going to get a new vein from the body somewhere, and we're going to bypass the blockage. I think there's some picture. So there we go. So here's the picture. If there's blockage right here, then we're going to bypass the blockage. If we've tried everything else, we've tried putting stents, it's not working, then we may have to do the bypass. So they start up here, sew in the new vein, and then sew it in below the blockage. And this one's not quite like a fin pop because it would really kind of go down here to the knee. It's very long when you have to do a fin pop bypass surgery. But that's the concept. We've got a blockage.
Does it specifically have to be a vein or an artery, or can I just pick one itself? Like that one you said is a vein.
Yes, this is a vein.
So it specifically needs to be a vein that they get to do the bypass?
Well, it doesn't have to be. Most of the time they use the what is the vein that they normally, the saphenous vein?
Saphenous, yeah.
Saphenous. And it's the largest vein in the body. And so most of the time they're going to use that vein if they can. But they can use them out of the arms, wherever they can get them really. And sometimes if it's really, really long, like if we have this that has to be bypassed, they may have to make a synthetic graft.
Yeah.
Okay? Because we don't have a vein that we can use that's that long, so they have to just make one.
So what do they do when they remove the vein? They remove a big portion of it, so how does it?
Then pretty much the rest of the veins in the body take up its slack.
Mm-hmm.
Because this is really going to be life-threatening to that limb. So if the veins are fine, then the other veins will just take up the slack of that vein. But this has to be fixed or we're going to lose that limb. Okay. Let's see how much more we have. So nursing assessment for, I think we're pretty close to the end of the arterial disease. Some nursing, subjective information that you're going to gather is going to be like, we're going to find out if they have any past or present history of diabetes, or do they smoke, do they have hypertension, high cholesterol, or are they obese. We'll ask them things about their functional health patterns, like if you're sick, you go to the doctor. Some people don't. They just wait till the last minute, and every time they end up going to the healthcare provider is to the emergency room because they just absolutely hate going. Ask them about their activity. Do they exercise? Do they have pain when they exercise? What do they eat on a typical day? If they do have pain, does it sound like that intermittent claudication? Is it rest pain? Or do they just have pain all the time in the lower legs? And then this is kind of like a review of your objective information that you'll be gathering. Obviously, do they have hair loss? What does the color look like? Is it pale? What about their pulses? Do they have present pulses? Are they weak or unequal? And then do they have problems with sensation? Do y'all want to take a break? Let's take a 10-minute break. Okay, so this was kind of a good way to lead off. So when we come back, here's kind of a case study. So we have BD that undergoes bilateral PTA with stenting. What's bilateral? Both sides. Okay, and so remember this is the percutaneous transluminal angioplasty where they go in there with the balloon and then they put a stent in as well. So what are some nursing diagnoses that you think would be appropriate for him? What you got? Decreased tissue perfusion. You think he's going to be in some pain? Probably they just stuck a catheter through his arteries, right? So activity intolerance, he's not going to be able to get up for a while. Most of the time, y'all know what artery they're going to go into. If we're going to the legs, what artery are we going to go in? The femoral. Okay, so he's going to have wounds bilaterally right here. So he's not going to be able to get up for a while. If he does get up, what's likely going to happen to those sites? They're going to start bleeding again. And is it hard to get an artery to quit bleeding? Yes, we don't want an artery bleed. He's going to have some impaired skin integrity because of the wounds. Let's see what else. Ineffective self-health management. He's got some knowledge deficit there. We're going to have to educate him on like diet and lifestyle, things like that. What would be some goals for him? Yeah, we want to reduce the pain. Eventually, we want to get him exercising and able to tolerate exercise. We want to make sure that those wounds heal, okay, where they went in with the catheter. Hopefully, we want him to have some adequate tissue perfusion after all that, right? What are we going to have to tell him about his medicines? Yes, from now on, you will take at least one pill every day, that blood thinner, okay? That graft will clot, or that stent will clot. Health promotion. We want to identify at-risk patients. We talked a lot about the diet, decreasing that cholesterol. The most important thing really is to educate your patient. That's one of the best things that you can do for them. Tell them to avoid injuries if they can. Make sure they wear proper foot care, that they're taking care of their feet, things like that. So, continuing on with that case study, DV comes to the recovery area after his PTA and stenting. He has bilateral dressings on his groin, and he's positioned supine, which is how? On his back. What are some of your top priorities for assessment on him post-operative? Perfect. That's going to be like your number one thing. Peripheral pulses, okay? If we have fixed what was causing that blocked artery, if we fixed it, then we should be able to feel a pulse, right? What happens if you feel a pulse? You say he's been with you for 15 minutes, you felt a pulse, then 30 minutes later you come back and you don't feel a pulse anymore. Pulse will clot, okay? That stent is probably clotted. Do you think that's going to be painful? Yes. He's going to have, a lot of times that'll be your sign that the stent has clotted, that they won't have any pulses, and they're going to have sudden severe pain in that extremity. So we talked about originally their capillary refills and other things that you can assess after like the pulse sites, the distal pulse sites. We're going to keep a check on that blood pressure because we do have arterial wounds now. We want to make sure that we don't have any skin changes or any temperature changes. What are some signs that they may be bleeding? Bruising, okay. If you see bruising or hematomas at that site, that means that they're bleeding into the tissues. What about their blood pressure? It's going to drop, okay. Heart rate is going to increase. Sensation and movement. Once we have good blood flow to that area, they should be able to have sensation, normal sensation in that foot. Then, if they have sensation when they come back from surgery or from their procedure and 30 minutes later they can't feel anything again, then that is one of your signs too that maybe they have a block. it's important to make sure that they stay supine for several hours. Remember we said if we elevate the head of the bed and have them in a sitting position, that's going to put pressure on their arterial sites, and it may cause those arteries to bleed. So we want them laying supine, especially no higher up than 30 degrees for several hours after that procedure, until we make sure that it's not going to bleed. So we got him through the recovery phase, and he's on his way to be discharged home. What will you teach him regarding immediate care and precautions at home?
Just stick to medication.
Medication regimen. Good. Okay. We want to teach him about the importance of foot care still. Okay. Still want to make sure that they take care of their feet. Gradual physical activity. They should be able to exercise normally, eventually, without any of the intermittent claudication. If they smoke, what are some of the management of risk factors? What about if they smoke? What's likely going to happen? Yeah, we want them to quit smoking once they go home, because more than likely if they continue smoking, if they continue eating like they've been eating, they're just going to develop another blockage somewhere else. Okay? And then when they're going home too, we want to make sure that they care for those wounds properly for a while too. Think about if they have bilateral arterial wounds, when we go home, do we want them lifting weights and picking up the kids and things like that? No, not for a while. I think what they normally tell them in the hospital, don't lift anything over the weight of a milk jug for like a week. Okay, three days to like a week. That's just something that you'll hear in the hospital or the clinic setting, because they don't want that extra pressure on those arterial wounds, because they can come unclogged, and then if they get home, they're probably going to bleed out before they get any type of medical care, especially if they live way out in the county. Some other things, these are just some nursing evaluations, things that you want them to do eventually. You want them to have knowledge of their disease and how they're being treated for it. You want them to exercise, get to walking, make sure that you want them to have adequate tissue perfusion now, things like that. So here's a question. The nurse teaches a patient with peripheral arterial disease. The nurse determines that future teaching is needed if the patient makes which statement, do you think? They need further education if they say what? B. I should cut back on my walks if it causes me pain. No, that is quite the opposite, okay? We want them to be exercising because we said walking is pretty much the best thing that they can do for PAD. Yes, it's going to hurt. You want to encourage them to stop and take breaks, but you do want them to exercise. Okay. Acute arterial ischemia. This is sudden interruption in the arterial blood flow. A lot of times this happens when stents become clotted, and it totally blocks blood flow. So they're not getting any oxygen to that extremity. It occurs suddenly. It usually affects one extremity or the other. Usually won't see it with both. And I kind of got a little video. It's just like a 1-minute video where you can kind of see the signs and symptoms of arterial ischemia.
So I'm making a video right now. I want to demonstrate basically what happens when you get a obstructed blood vessel to your to your leg. This gentleman's agreed. We got some pain control on board, so I think he's getting better. But can you tell me a little bit, sir, what happened?
Well, I woke up and I had a pain in my leg, in my groin. And then I lost all circulation in my right leg, and it's like I was having a stroke. I couldn't move my leg, couldn't bring it up or down or side, couldn't move my toes.
So you have no motor movement at all. So
No.
if I slide back down here, try and move both toes, both feet, and try and move the other one.
I am.
Okay, so you just can't use anything. And then it started to get cold, started to get blue, mottled.
Yeah, it started hurting.
Okay, scale of 10, how bad's the pain?
9.
9, okay, was
Had
it?
to leave the whole room.
Okay, all right.
So that kind of gives you the signs and symptoms there. He gets a little bit upset and starts cussing later on, so we won't. So that just kind of helps you with the signs and symptoms of acute arterial ischemia. So thinking back on the video, was he in pain? Yes, he was in severe pain. They said we've got some medication on board. What about pallor? What did it look like? It was blue, kind of up towards the top, but I don't know if you noticed when he was asking him to move them, that foot was really white. It was really pale. So and that's kind of how blood flow works, right? The lowest part of that extremity is going to turn paler before the upper part, okay? Because that's how the blood flows. Do you think there was a pulse there?
No.
No, it was completely obstructed. There was no pulse. Numbness, tingling, did he have numbness and tingling? Yes. And then did he even have some paralysis? And that's a very late sign of the disease progression, okay, or the occurrence of that disease. And with the paralysis, you know, the nerves are dying. The nerves have died, so he's not able to use that extremity anymore. And we need to treat him quickly, because it may progress to tissue necrosis and gangrene. And then what has to happen to that extremity? You have to have it amputated. But even with him having the paralysis, even if we get blood flow back to that extremity, more than likely he may not regain the ability to use that limb anymore because of the nerve damage that it occurred. Like we said, early diagnosis and treatment is essential to save that limb. They're going to start them on heparin IV. That's the anticoagulant therapy that they're going to use. And sometimes they have to go in there and remove the blockage. That's your embolectomy or thrombectomy. And then on, more typically you'll see the thrombolytic therapy with pulmonary embolisms because it's such a risky medication to give, but they can be given if they need to dissolve the clot. So important thing to remember, anticoagulants, they're going to help thin the blood, but the thrombolytics are what dissolves the clot, okay? So even if we just give them heparin, is that going to get rid of the clot? No, okay? Heparin just thins the blood, thrombolytics dissolve the clot. The next disease is Berger's disease, and it's a non-atherosclerotic inflammatory disorder. It usually occurs in young males, and the cause of it really isn't quite understood, but it has a strong relationship to smoking and nicotine. Something in the smoking and the nicotine causes this inflammatory process to trigger. This is kind of what it looks like. You have this picture in your PowerPoint that I can add pictures later to y'all's. So it's often confused with EAD. They have the intermittent claudication of the hands and the feet. And basically what happens is the smoking and nicotine causes the blood vessels in the fingers and in the toes to constrict and become occluded. So no blood flow goes to that area. And it is progressive. This didn't just happen overnight, okay? This was a long process. Probably somebody that was bound and determined not to quit smoking. And you can see the color changes. Obviously, there's going to be some temperature changes there. More than likely, they're not going to be able to use that extremity. And pretty much, if you don't go and get these amputated, your body's going to auto-amputate those, okay? Just because of the necrosis and death of the tissue, and it basically just dies. So our treatment for them, the big star beside not smoking, okay? Is that they are just bound and determined to smoke with these patients. They can't even use nicotine patches. There's something in the nicotine or in the cigarette smoke or in the dip that causes this vasoconstriction in the toes and the fingers. Patients must choose, they can't even, yeah, that's a good thing too. Secondhand smoke, they can't even be around that either, okay? So, they don't even get the benefit of, like, you know, tapering down or anything. They just need to quit cold turkey, be done with smoking. They have to choose between their limbs and smoking, okay? Because the picture that I showed you before, their whole hand will do that. All of their foot will do that. It will just basically rot away. They'll have ulcers. They turn into ulcers first. They're big open wounds, and then they turn to the black necrotic tissue eventually. Obviously, they're going to have to be amputated, or the body will auto-amputate them. So, like this. See, his body's auto-amputated that part of the finger. It just rots away. It'll fall off because there's no blood supply to that at all. The next one is Raynaud's phenomenon. It's very rare too, but this one, it's not quite as severe. A lot of times you see this in women. It can be primary, which means it occurs pretty much all on its own, and as they age, usually after their mid-40s or so, it kind of just disappears. Or it can be secondary, which means that it occurs in response to another autoimmune disorder, and it usually develops later on in life. But anyway, with Raynaud's phenomenon, their fingers and their toes go through a process of vasoconstriction and vasodilation, and it's usually pretty rapid. There's a couple things that kind of trigger it, but that's the gist of it. Their fingers and their toes just spontaneously constrict, and when it constricts, it's going to limit blood flow. So you'll see, I like to call it the red, white, and blue disease. That helps you remember it because their fingers literally go through those color changes. When blood flow is first constricted, it turns pale or white, and it almost looks like their fingertips have been dipped into paint. This is literally what it looks like. But first of all, it turns pale due to the lack of blood flow. Then it's going to turn blue because after so long, without blood flow, it's going to be blue. And then their body or their blood vessels go into vasodilation. So it's like a rapid release of blood flow to the extremity, and it turns red. And then it's normal for a while. And it's just kind of spontaneous. Like I said, there are a couple things that trigger it. We'll talk about, I think it's on the next slide. But their hands and their feet just go through that process over and over. They may have a couple episodes a day. They may have weeks between episodes or months. It's kind of random. But here are your clinical manifestations. They have the vasospasms. That's what let's see. Sometimes it can occur in the nose and the ears too in like really severe cases, but most of the time you're going to see it in the fingers and the toes. It's obviously going to be cold. They're going to complain of some aching, and then some swelling when they get that rapid vasodilation and the blood goes back to the extremity. They'll have some swelling there as well. There's the triggers. Those are most commonly the triggers. Exposure to cold, emotional upsets, caffeine, and tobacco. Those are your 4 most common triggers that can cause somebody to go into this vasoconstriction and vasodilation. So if we know those are the 4 triggers, then we're going to tell them to kind of avoid exposure to cold, obviously. We can tell them to wear gloves. If they're going outside and it's really cold, we can tell them to put those little warming hand things in their pockets to keep their hands warm. Obviously, avoid caffeine and tobacco. And then if they have emotional upsets that's causing their vasoconstriction, then really, I guess we can put them on some medication for that, or we can help them to develop some stress management techniques. If we've tried all those things and it's still not helping them, they're still having those periods of vasoconstriction and dilation, then we can try putting them on a medication. Usually these calcium channel blockers are the most effective in treating the Raynaud's. Preferably the Procardia is what they're going to be put on. Some people, the Cardizem works better, but more than likely, just the calcium channel blockers is what we're going to put them on. So we finally made it to the venous diseases. So venous thrombosis, which is just a clot in the vein. It's the most common disorder of PVD, okay, or the peripheral venous disease. Most of these are going to be dealing with a clot. We have 2 different types of venous thrombosis. We have superficial vein thrombosis, or we have deep vein thrombosis, which most of the time you're going to hear it called DVT. And I put this on there just because your textbook uses VTE, venous thromboembolism. Most of the time in the hospital setting or clinical setting, you're going to hear DVT on there. So there's 3 important factors in the etiology of a venous clot. The first one is venous stasis, and we'll talk about damage to the endothelium, and then hypercoagulability of the blood. So with venous stasis, that word basically or literally means slow blood flow. So this is when the blood in the veins just kind of sit there. They pull in the extremity and they cannot get back to the heart. There's some of your risk factors for venous stasis. When we're immobile for long periods of time. So, if you're on a long flight or if you travel across the country for a long time, that's what your doctor's like, don't sit still, you need to get out and move at least every 2 hours. Because literally our leg muscles, arteries have the force of the heart behind it to pump it to that extremity, and they usually have gravity behind it to help get it where it needs to go. But our poor little veins, they don't have much force at all to get back to the heart, do they? No. They have little valves in the veins that help to push blood up to where it's supposed to go. But a lot of our veins rely on our muscles that surround it to contract and to push it where it needs to go. Okay, so if we're not using our muscles, then a lot of times that blood just sits there and gets stagnant. Then endothelial damage, that's the cells that line the inner surface of every blood vessel. And so if it becomes damaged, it pretty much triggers a clotting cascade, which we'll talk about in just a little bit. But some things, like in the hospital setting, that can cause endothelial damage, if we put in an IV or if we puncture do some venipuncture, or if we have an IV that sits in the catheter site or in that vein for too long, it can cause damage to that endothelial and it can produce a clot. And then hypercoagulability, blood disorders can cause the blood to be too thick. So like here, polycythemia, if they have too many red blood cells, then there's not enough plasma. So then it makes it really thick. Anemias, if we have too much iron in the blood, it can cause it to be really thick. If we have some type of cancer, it predisposes us to thick blood. And then we have the antithrombin, protein C and protein S, which are, when we talk about the clotting cascade, these are the proteins that are secreted so that we don't keep clotting our blood. Okay, so we'll talk some more about that. But if we have trouble with these or we have a deficiency in these, then our blood is going to be too thick. And then sepsis, those are like toxins. The toxins in somebody that has sepsis predisposes them to thick blood too. Some other important things, some medications can cause us to have thicker blood. So women that are on oral contraceptives, that predisposes them to DVTs actually. So if we have somebody that smokes, that predisposes them to DVTs. So if we have a woman that smokes and is over the age of 35, they are very high risk, especially if they have a family history of DVTs. They're at very high risk for blood thickening or DVTs. So this is kind of like the pathophysiology of how a clot forms. You know, if we have damage to the vessel, or if we get our arm cut off, we want our body to form a clot, right? At least try to if we get our arm cut off, right? So basically what happens, you can kind of see over here, we have RBCs, white blood cells, platelets that are just kind of circulating through the blood, and when they see some type of damage, our platelets kind of go to that area and try to form a clot, okay? And then eventually after the clotting cascade, which we'll talk about in just a minute, we'll have the fibrin threads basically that kind of connect it all together and make it real secure. So if we're bleeding out somewhere, then we want our body to do that. But sometimes when in our veins, they just become stagnant and it gets clotted where it's not supposed to be clotting and causes a thrombus. And you can kind of see here, so like if it started here by this little valve and it just kind of grows and grows and grows and grows. It may eventually occlude the entire lumen, or it may become detached, and that's called emboli. An embolus may travel through the circulatory system and lodge into the pulmonary system, and that's known as a PE or a pulmonary embolism, and that's really, really bad. So we'll talk about that some more in a minute. So, the clotting cascade. So, like we said, if there's something really wrong with us, we want our body to initiate this clotting cascade so it prevents excessive blood loss. We talked about it forms a thrombus, and then there's two systems that work together. Whenever our body starts to bleed, it automatically vasoconstricts, and then it relies on these two systems. First of all, we said the platelets are going to go to that area and kind of aggregate. And then the clotting cascade or the coagulation cascade gets initiated, and that's where our fibrin comes in. Okay? pretty much what we just said. There's 3 important things that the platelets do. They rush to that area, stick together, they aggregate, and then they initiate the clotting cascade, which will get us fibrin. The goal of the clotting cascade is to form fibrin. We actually want a fibrin clot, which is basically just one step on fibrin. All of the factors, in the next picture I'm going to show you the pyramid basically. All of the factors have an active and inactive form. So everything that we need to produce fibrin is floating around in the inactive form. Then once platelets or some type of damage triggers the clotting cascade, they become active, okay? And it's kind of like a sequence, like a step-down sequence. And then when you see it on paper or whatever, once they become active, the factor will serve to activate the next factor. And so A denotes the active form. So we have factor 12, it gets converted into active factor 12. It'll make more sense once you see the diagram. Okay? Okay, here's the clotting cascade. So we have an intrinsic pathway, or we have an extrinsic pathway or an intrinsic pathway over here. So depending on how it gets initiated, it will all eventually lead to this fibrin clot, okay? So basically, what does extrinsic mean? Something outside the body, outside the cell, initiates the clotting cascade, okay? And most of the time, it's tissue factor. So once the blood or the plasma comes in contact with the tissue factor, it initiates this process, okay? Remember I said, I know it looks complicated, but let's try not to overthink it, okay? So the tissue factor is like a sequence. It's a step-down thing. This action has to happen in order for this action in order for this action, okay? So tissue factor and factor 5 form a complex which activates factor 10, okay? Does that make sense? Okay? So there's some type of external damage that exposes the blood to tissue factor, okay? So with tissue factor and factor 7, they form a complex, okay? So they team up, and because of their complex or them teaming up, it turns that inactive factor 10 into an active form, okay? Does that make sense? You good? Okay, and then from there, that's the intrinsic pathway. This is the common pathway between both of them. We'll go over. So from there, factor 10, it activates the prothrombin activator, okay? In prothrombin, sometimes you'll see it over here, I've got it. Prothrombin, sometimes you'll see it as factor 2, okay? So however you want to remember that. And then its active form is thrombin, which is F2A. So the prothrombin activator activates prothrombin to convert to thrombin. And then so once thrombin is in the blood, prothrombin turns fibrinogen into fibrin, okay? So all of these factors are in our blood just circulating around, but something has to trigger it to convert to its active form. Does that make sense? I know it's complicated, but just remember it as a process, okay? We have to have this first, and then that converts this to this, okay? So all of these are in the blood, but they just have to be converted by whatever's above it. Okay, so it's a step-down thing, okay? So with intrinsic pathway, what does intrinsic mean? Something that happens within the body. So within the body, most of the time it's going to be the blood is exposed to collagen, and it triggers the clotting cascade. So from here, so the blood coming in contact with collagen activates factor 12. Okay, so you can see it activates factor 12. So factor 12 then activates which one? 11. 11 activates which one? 9. And then 9 activates which one? 10. And then we have that common pathway. Okay? So factor 10 ultimately activates what? Turns prothrombin into thrombin. And then prothrombin turns what? Converts what? Fibrinogen into fibrin. Okay? Do we want to go over it again? Good? Alright, so then, remember we said our ultimate goal is to produce the fibrin. Okay, and then factor 13, activated factor 13, combines with fibrin to produce that fibrin plug, which kind of meshes it all together. Those are the little strings you see. Okay? So basically your big things to remember, extrinsic pathway starts with your tissue factor. It's exposed to tissue factor. Okay? Intrinsic is the collagen. Okay? And then it's just a matter of remembering the process. Okay? So which factor activates which factor. Once we get to that fibrin clot, okay, do we want our body to keep producing blood clots? No. So we have some factors that inhibit clot formation. And that's the ones that we talked about, the protein C, protein S, and the antithrombin. So I think it's, let me make sure. So once thrombin is activated, the blood also releases natural anticoagulants. And so your protein C, protein S, and your antithrombin are your natural anticoagulants. And basically they just help to inhibit that factor 6, 7, 8 and factor 5. Okay? So when we get to right here, so once our clotting cascade gets to the thrombin, once thrombin is active, then it also produces that protein C, protein S, and antithrombin too, because we don't want to clot all of our blood, okay? We just want a little bit, okay? Just enough. And then we want it to start thinning again to its normal level. Yes. So, yes. So, protein C, protein S work to inhibit factor 8 and factor 5. Okay, and then antithrombin it blocks 11, 9, and 5.
Where is the 8 and 5
So some of these have cofactors as well. Do they need to know the cofactors?
No.
Okay. That's why I didn't put them on there.
Yeah, that's getting too deep right now. You just, basically need to understand the clotting cascade and that.
There's a process to it.
Yeah, flip to the next slide. And so you'll hear some people, like I have a clotting disorder. Okay, my blood clots too much. And so some of the first things they did was to check for the factor 8 and the factor 5 to see if it was one of those, because those are probably our most common two. that they like, it's related to them. And it's like they clot too much, you know, then you have too much of that. But yeah, just know the basics and understand the process.
Yeah. So just know there is a process, there are steps. They have to occur in order for everything to get activated, basically. Okay? Don't overthink it. Don't make it more than it is.
Yeah, and I'll just say this and just throw it out. You don't have to know this for the test, but just so it kind of clicks and makes sense. The thing I'm fixing to say, you don't have to know for the test. You'll learn later on about hemophilia. Y'all have all heard about somebody having hemophilia, right? And they call them free bleeders. They don't have the ability to clot their blood at all. And that's because they're totally missing factor VIII. Okay?
Which is, if you wanted to know, is the cofactor for 9. So 8 and 9 work together. When we talked about,
Right.
Some of them have cofactors.
So just to show you how it works, so you can also have the other extreme. So those people genetically, that's a genetic disease, and they're just totally missing factor VIII. They don't have it. So yes, because of that, they're going to bleed freely or too much.
Are we good now? They're like, we don't have to know for the test. Yeah, we're good. But yeah, so you have some cofactors in there as well, and that's where the protein C, protein S, that kind of comes in. Okay. They have to occur in order, like we said, and we need this to prevent excessive bleeding and excessive clotting. So some of the disorders, we have the superficial vein thrombosis, which was the first one that we talked about. It's kind of similar to a DVT, just not as serious. Okay, we don't worry about this one as much. You will have it is a little clot, but it's in a superficial vein. It's not like in a deep vein. So you'll have the tenderness, they'll have redness at the area, and it may be warm. Like if you had a red spot on the left leg and you felt it, it may be a little bit more warm than on the right leg, the same area. They will have pain with it, and there may be inflammation. You may be able to see the vein that it's in. It may be like, y'all remember when you saw like phlebitis, what it looked like? It kind of looked like that, like a red line. There will be edema, and then immobilization, so it's probably not going to move. That's why we don't worry about it as much. They're not as severe, and more than likely it's not going to move and go anywhere else. So. Typically, we treat the symptoms because, like we said, it's not really a big issue. It's not going to move, so more than likely the body is going to heal itself. We have the body will pretty much dissolve the clot on its own. I think there's a slide about it later. But some things that we can do to treat the symptoms, we can let them use warm compresses, tell them to rest, elevate the extremity to help with the blood flow. We can tell them to wear the little TED hoses.
This is the treatment of the symptoms of superficial.
Yes. No, more than likely it's not. That's why it's not as severe. It's in a smaller vein. It's not usually going to move. It usually heals itself. It's not really much to worry about. And we can give them like NSAIDs or some other mild, pain medicine for it. They will have some pain and swelling, but. The deep vein thrombosis, on the other hand, is one that we worry about. We're going to do a little bit more extensive treatment on them. This usually occurs in the legs. Sometimes, more than likely, they're going to have some symptoms. They'll have pain in the, usually in the calf muscle, it feels like. They'll have maybe some redness. Unfortunately, some patients don't have any symptoms until it dislodges and goes to the lung. which is pulmonary embolism. And so it may have started out as a DVT, they didn't know they had it, and then it progressed, moved, and went to the lung. We're kind of running out of time, so we're not going to watch this little video, but it's there if you want to go watch it. But it's just the home inside. It's just a little procedure that they can, or a little test that they can do on the leg. It's pretty much where they put the leg up and dorsiflex the foot. If they have severe pain in the calf, then it's likely that they have a DVT. But we don't usually use it anymore because if we pull up on that foot and kind of squeeze on the calf muscle, it could send it into an embolism, and then it would go to the lung. And so then we have a whole lot of complications. So I think even in the video they say this is the home inside, but more than likely you're not going to see it going. But for some reason it's still in all the textbooks.
I know, they're trying to get it out. But yeah, according to National Council, it's not evidence-based practice anymore, so we wouldn't check. Because I know when I had my first DVT, and I was in the hospital, and one of the nurses came in for her new shift, and I knew what she was fixing to do. She got my leg, and she said, I was like, no, stop. And she's like, I said, stop. You know, do not. And I was like, I didn't want to be a rude patient, but I'm like, no, you're not going to do that on me because you could break more of the clot off. And she hadn't heard of that yet. So, you know, oops, because, you know, when she went through school, so that's a problem we have also, is getting that information, you know, distributed once people have graduated and they're practicing.
So the most serious complications of DVT is going to be the pulmonary embolism, but it can cause chronic venous insufficiency and something called phlegmatigia crulia dolens, which I'm sure it's some type of Latin word or something, but it literally means painful blue edema. That's what that word means. And so I kind of got a picture of it. You can kind of see that does look painful. That leg is obviously blue, and you can kind of see some edema. It's not a whole lot of edema. But a lot of times this is a complication of cancer patients when they get a DVT. I think they said like over 50 or 60% of the cases where you see this, it's some type of cancer patient. So some diagnostic things that we can do for DVT. We're obviously going to look at blood levels. The platelets, more than likely, if they have a clot, then their platelet level is going to be elevated. Some other things that we look at are the PTT, PT, and those are measured in seconds, okay? And this just tells us how fast the blood is clotting. So if we have, I think there's a page in your textbook that kind of gives you these values. I didn't write it down. And so, I don't think the values are really important right now, but just understand the concept of like, so like a PT normal is 25 to 35. If we had a low PTT like 10, what's that tell us? It's clotting too fast. Yeah. So the lower the score, the faster the blood is clotting. And so if we have a high number, so like 55, then we know our blood's clotting too slow. But so in DVT or clotting disorders, it's going to be low. Okay, so the number will be low because it's measured in seconds. 25 to 35.
So look it up in your book. I just don't want to quote you, but you do need to know the labs for clinical and for the tests. So look up your PTT, PT, and your INR. So if we had somebody on heparin, if we had somebody that clotted too much and we started them on heparin, then we would want theirs to get higher so that their blood wasn't clotting as much. So we would want it to.
And so like, you know, when we have somebody that has thick blood, we obviously want it to be thinner maybe even thinner than like the normal range, especially if they have a blood clot.
And I will say, you need to know that if you have somebody that is on heparin or Lovenox, the tests that we use to see if we've reached a therapeutic level, like got it as thin as we want to, okay, is the PTT.
It is later on in there.
Oh, I'm sorry.
It's
Okay.
fine.
But if you've got somebody that's on Coumadin, then you use the PT or the INR. And that's really for warfarin only.
So there's some other tests that they can do where they go in and like visualize the veins, or they can do scans of the veins. The lung scan is going to look at ventilation and perfusion. The spiral CT scan kind of, you're able to see segments of it. But most of the time the blood tests are going to help you determine if there's a clot present, and the scans and things like that are going to basically tell you where it is. So, first and foremost, we want to prevent people from getting DVTs. So, things that we can educate them on is to stay active, or if they've had surgery, we want to get them up and walking as quickly as possible. A lot of times, if they come into the hospital, they just don't move around as much as they would at home, whether they're sick or there's just limited space for them to do that. So a lot of times, they're going to go ahead and put them on blood. You probably all gave one in the clinical area by now. Low injection, Lovenox shot. Most of the time, everyone's going to be put on one of those unless it's contraindicated, just to help with that thinning of the blood while they're in the hospital. We talked about the TED hoses that we can put on for venous diseases, or the compression devices like the SCDs. Okay? If somebody can't move around for themselves, we're obviously going to provide some range of motion and position changes, stuff like that. So actual treatment for a DVT, some non-pharmacological things that we can do. We obviously want them to stay in bed. We don't want them up walking around and exercising, because that could send that clot loose and straight to the lung. We're going to help, we want them to elevate the extremity. We can give them warm compresses for the pain. Drug therapy. Anticoagulants obviously are going to thin the blood. And there's the fibrinolytic system that will, that's the part in the body that's just going to naturally dissolve that clot. So sometimes we can just give them anticoagulants to help thin the blood, and then our own body will dissolve the clot. Because like I said, that with thrombolytic therapy, you have some serious complications that can result from that as well. So we try not to put them on that unless it's really severe, like pulmonary embolism, or we're worried about it turning into a pulmonary embolism. So there's your stuff about heparin that she was kind of telling you. We have unfractionated heparin or heparin sodium. It's usually given IV, so they'll come in on a kind of like an IV drip. It can be continuous or it can be intermittent. So intermittent means that we may turn it on for a little while, check some blood levels. It may be therapeutic or it may be too high, so we turn it off for a little while and go back to it. So it may be off and on. But most of the time, that one's the one that is initiated and used IV. Most commonly, your blood level is going to be the PTT. Sometimes they'll look at the anti-10A. And here's your antidote for heparin, rhodamine sulfate. And then after they kind of come off the IV therapy, or here's the one that we use just as they come into the hospital to prevent blood clots, is the Lovenox. And this is pretty much the same. We're going to look at the PTT, and the antidote is the same as well. And here is a little picture that I kind of added last minute, and I can make the PowerPoint that Dr. Henry can send out to y'all later if y'all like this kind of stuff. But basically, heparin works to prevent thrombin to converting into the fibrin. Okay, it inhibits that connection. But it's got some stuff on there that may help you remember kind of what it does, what it's for, that kind of stuff. Drug therapy. And like I said before, Pinterest has a lot of these too that you can look up. Those little diagrams help you. And then Coumadin is usually given PO. And like she said earlier, we're going to look at the INR level or the PT level. Most of the time, it's always the INR. And the therapeutic range is 2 to 3 for INR. So that's not like the normal level, but if somebody's having really thick blood, this is the therapeutic level that we want them at. Does that make sense? So if you check my INR level, it's not going to be 2 to 3. But somebody that has a stent in is going to be 2 to 3. Okay?
Or somebody that's walking around with a blood clot in their leg like me.
Yeah.
And I've already had to, to prevent another one, then, they would want mine to be between 2 and 3.
So patients may start out in hospital on IV heparin, and they may start Coumadin at the same time, but it's going to take longer for Coumadin to start working. So that's why
They do what they call a Coumadin-Lovenox bridge in the beginning.
Okay.
And so they're given the Lovenox, and it works quicker, but it takes a long time, sometimes up to 10 days to get that, if they're just starting you on Coumadin, to get it up to a therapeutic level between that 2 and 3. And usually if it's your first DVT and you're just being started on these meds, they're usually not going to let you go home till that INR is between 2 and 3. And then once the Coumadin is therapeutic, then they'll stop the Lovenox. Does that make sense? Because now they're just keeping them on that Lovenox to do the work, because it's effective almost immediately until the Coumadin gets to its therapeutic level.
Okay. So if somebody has a blood clot or a DVT, more than likely just a small percentage of patients usually have to end up having surgery from it. The common thing that they can do, especially if they have often or repeated DVTs, they can go in and surgery. Well, it's kind of like a procedure. I hate to say surgery, but a procedure that they can go through and put a filter in the vena cava, usually the inferior vena cava, to help filter out those clots so that they don't develop into DVTs.
I have one. I really want it out, but I have a filter right now. It was about like a IV stick. I expected it to be really bad when they said, "Oh, we're not going to sedate you at all." I was like, well, wait. But it was kind of like an IV stick there in the femoral area. But they said taking it out is a lot worse. They sedate you for that. But if they retrieve it, the filters now are retrievable.
So some nursing management things, y'all can kind of just read through those. But we'll monitor blood pressure, vital signs. We're going to look for blood in the urine and stool. We want to avoid IM injections because they're really easy to bleed. If we can, minimize vena punctures, things like that. Some more education things. Tell them to use a soft toothbrush. They need to use only electric razors to prevent, they can bleed out from just a razor scratch. All that other stuff we really kind of talked on. They bruise really easy, so perform ABLs gently. If they're on blood thinners already, we want them to avoid NSAIDs and aspirin or aspirin-containing products, because that's going to thin the blood even more. So it may be hard to monitor and keep them at a therapeutic level if once a week they're taking an NSAID or an aspirin for pain or something like that. Coumadin. I don't think I mentioned that when we were on the Coumadin slide, but your antidote for Coumadin is vitamin K. and it's found in green leafy vegetables. So if they're on Coumadin, we're going to have to tell them to avoid eating green leafy vegetables, okay? And that will basically reverse the effects of Coumadin, make their blood thicker. If they're on Coumadin or some type of blood thinner, we want them to wear a medical ID bracelet too. That's a good practice. Just if they fall out or if they hit their head or something while they're in public and maybe somebody not familiar with them, they know that they're on a blood thinner. So pulmonary embolism, we've talked a lot about this, but this is basically just a clot that goes and is lodged into a pulmonary artery. Here is another picture. It's kind of the pulmonary emboli highway. Starts out as a DVT, it breaks off, it goes through the right side of the heart and into some pulmonary artery. Okay? There's some other little things on there that may be helpful for y'all, and I can get you that picture later. The common symptoms of a PE is sudden and severe dyspnea. They have trouble breathing. That's going to cause their heart rate to go up. That's going to cause their respiratory rate to go up. If somebody can't breathe, they're obviously going to be anxious. And they may have some hemoptysis, which is like coughing up blood too. A massive PE, these are just going to be, the symptoms are going to be more severe. The risk of mortality is greater if somebody has a massive PE. The patients may even collapse. And if they are conscious when they have this, it's pretty much all the same symptoms, just more severe. They may have an impending sense of doom. Like I said, more than 60% of patients with massive PE usually die, and if they do, it's usually within the first hour of symptoms. There's another picture that's kind of got your signs and symptoms on there that I can get you later. It's got the different medications on there too. Complications, pulmonary infarction, which is death of the lung tissue, is the most common complication of a pulmonary embolism. A pulmonary hypertension is just a type of high blood pressure that affects the arteries in the lungs. And it usually occurs after several PEs. They may have this type of hypertension. It usually doesn't have to happen after just one PE. It's frequent. And unfortunately, death is a complication of a PE. Here's your different diagnostic things for a PE. We're going to go in and visually look at the lung, basically. There's different things that they can do. They can look at ABGs. If you're taking care of a patient and you think maybe if they came to you with a DVT and then they start having these symptoms and you think it may be a pulmonary embolism, the most important thing to do that you can do quickly is to elevate the head of the bed, at least to Sim Fowler's position. So once you get them elevated, then you can put on oxygen, make sure that they have an IV access, try to calm them, but usually they're going to be very anxious, have that impending sense of doom, and just try to stay with them. We talked a lot about heparin and Coumadin. Sometimes with PEs, we're going to start that thrombolytic therapy, which is given through an IV, which dissolves the clot. Remember we said antiplatelets just thin the blood, but the thrombolytics are the ones that dissolve the clot. Okay? And then sometimes they have to go in there and surgically remove the clot out of the lung, which is very extensive. And then if they have repeated pulmonary embolisms, they're going to put that filter in there as well. But the thrombolytic therapy, they really kind of use that for just pulmonary embolisms because that really, they have an increased risk of like hemorrhaging and things like that, intracranial hemorrhaging. So they like to kind of reserve that for last case scenario. There's some stuff about thrombolytic therapy. Education, it's pretty much the same. Once they get ready to go home, pretty much the same education that we would provide for the DVTs. I think there was 2 slides about that education. Important things though would be to avoid that vitamin K because that's going to clot the blood. Chronic venous insufficiency. These are when valves in the veins that do not work properly and cause damage. It's usually caused by damage from previous PEs or DVTs. It's really common in elderly people. It's not life-threatening though, but it does cause a lot of pain and they have a decreased quality of life. Some of the other things that cause it, but more than likely it's going to be caused from those DVTs. Here's your signs and symptoms. They have the lower leg that appears leathery or hardened, kind of like the signs and symptoms that we talked about at the beginning, that stasis dermatitis. It's like that reddish brownish color. They'll have edema, and they may have the pruritus, which is itching. They may complain of itching with lower extremities. Here's a picture of the venous stasis ulcers. And we talked about them at the beginning. What are some things that you notice that are different than the arterial? The regular borders. What about the location? Ankle or lower leg. What about their color? Are they a little bit different? Yes, they're real red. So, there's your signs and symptoms, or your characteristics of the venous ulcers. And then there's a good table in your book on page 804, table 37.1, that has a good comparison of your arterial versus venous leg ulcers. Your treatment for ulcers, we want to do moist environmental dressings. We just want to keep it moist. That helps to promote healing. We want to make sure they eat a lot of protein. We want to try to avoid infections, but if they do get an infection, we want to treat it with antibiotics. And we want to encourage them to use their NCDs or their TEDOs, which is proper compression stockings. Teach them proper foot care. We want them to elevate their legs frequently. Okay, we want to encourage them to elevate them at least 3 times a day, something like that. Try to get them walking. That helps promote blood flow. And then your last one is varicose veins. And these, I know a lot of people think about varicose veins being spider veins. Varicose veins are like a severe form of spider veins. The veins become dilated and they twist. So they look really, really nasty. They're pretty much due to a weakness of the vessel wall. Pretty much what causes them. So a lot of times venous stasis, or that stagnant blood that stays in the vein, causes the valves not to work properly. We can have varicose veins. Most of the time we think that they'll be in the legs, but they can be in the esophagus or even in the anorectal area, which they're called hemorrhoids or esophageal varices. Probably learn more about those later on. The etiology is really unknown. Like I said, it's just something about the valves in the veins of the legs. They just don't work properly anymore. They become twisted and dilated, and so the blood flow is just not great. One of your most common causes of varicose veins are standing or sitting for long periods of time. So a lot of times nurses will have these varicose veins, especially once they get older. Something for y'all to look forward to.
There are other people that stand on their feet a lot. besides nurses. Cashiers, bank tellers, and another real common one are cosmetologists. You know, or people that, because, you know, do your hair. They're constantly on their feet all day.
Here's the clinical manifestations, and I kind of like this picture. Pictures help me a little bit better than just the text, but they can be in any size. A lot of times they're on the lower legs. They can be in the arms, but it's not as common. A lot of times they may be painful when they sit or stand for long periods of time, but they're usually relieved by like walking around or elevating Your prevention obviously is going to avoid sitting or standing for long periods of time. If somebody's obese, that puts more pressure on the arteries and the veins, so we want them to have an ideal body weight, properly care for their legs, encourage them to walk, wear their compression stockings. When are you supposed to put on, like if you're a nurse and you're fixing to go to work, when's the best time to put on your compression stockings? Before you even get out of the bed. That's the best place. So that's what I try doing that with, you know.
I know.
Life goes on. You
Like I
forget.
got a
But
warm.
I try to put them on my bedside table, and before I get up in the morning, I'll be laying in the bed trying to put them stockings on. But you know, then life gets in the way and you forget, and so you just don't care anymore. But that's best practice. So you know, you want to try, and that's just to, you know, once you stand up in the morning, that blood all kind of goes down by gravity. Okay. So it's best to put them on before the blood even gets down there to calm back. Then, last slide. Treatment, there's a couple different things that they can do. Sclerotherapy, which is just a medication that gets injected into the IV, and it basically chemically destroys them. They can do surgical ligation, which basically just removes the veins. And then most commonly I hear about the laser therapy, where they just kind of go in there and cauterize and close those varicose veins. I know I ran through that last section. Do y'all have any questions? Kind of try to figure out.
Well, remember, y'all got to take your
Yes.
post test, so don't pack up.
You have about 5 minutes. Can you go ahead and do those post